Good morning, everyone, and welcome to our webinar, which is a follow-up to one we had done about 8 months ago with Dr. Don Sin, bringing us up to now 1 year on COVID, and we sort of getting an update on where we are from a testing perspective. We've been into this issue with COVID for actually a little over a year, and in theory, we hope that we're sort of coming out of the second wave. The vaccines are very slowly on the way. We are unfortunately well behind a lot of other countries. But it begs some questions like, where are we now? How are we doing? And maybe more importantly for all of us, where is this all going? And Dawn is going to answer these and many other questions, especially about rapid testing, where it is, where their particular experiment with in St. Paul's is falling, and what that might mean as we take a look at sort of getting back to some sense of normal. The backstory from last summer was that we first met at the end of June. By that time, if you remember, the first wave had crested and had calmed down considerably. People were actually out and about, not in a normal fashion, but there was no massive serious lockdown. And we were about to enjoy what turned out to be a pretty reasonable summer, having maybe little idea that a much larger, more massive second wave would occur. And that has lasted all winter long and only now started to abate in some measurable way in Canada and in large parts of the rest of the world. So today, let me first maybe give some background for those of you who don't know Don and his work at St. Paul's Hospital. Don is the director of the Heart-Lung Innovation Center at St. Paul's. He is the chair tier 1 in COVID and respiratory physician at the hospital as well. And also he is a professor of medicine at UBC. He's considered, and I think this is amazing, Dr. Sin has considered the top medical expert in COPD across North America and the second in the world. So we are very fortunate to have somebody with his expertise and knowledge speaking with us today. So the format will work this way. Dawn is going to present for about 30 minutes, and please, while that's going on, take a look. If questions arise, please forward them on, and then I will handle a Q&A for the last 30 minutes of our time today, and hopefully we'll be able to cover all the questions that come through. So with that, Dawn, may I pass this over to you, and we'll regroup for questions and answers in about 30 minutes. Thank you.
Well, thank you so much, John, and thank you for inviting me to this seminar again. As John mentioned, it was about 8 months ago that I gave the first of these seminars, and now that 8 months have passed, I think we have a better perspective on COVID, not just in Canada, but throughout the world. So let's see if I can, John, can you see the screen?
Okay. Don, I see the screen. It looks great. Nice, very clear.
All right, very good. Thank you. And this is the old, the current St. Paul's, and this will be the new St. Paul's Hospital that was just announced yesterday, which will be implemented in about 5 years. So we all look forward to that. So this is a map of COVID-19 death throughout the world, and today marks the 1-year anniversary of the first death that was reported in Vancouver. So it's a bit of a grim milestone, but it is indeed a date to remember. Throughout the world, there have been more than 2.6 million deaths directly attributable to COVID-19. And the highest numbers have occurred in the United States, where more than 500,000 have died. Brazil, where over 260,000 have died, and the United Kingdom, where over 120,000 have died, and the numbers are continuing to climb. In Canada, we fared a little bit better than these countries, and our overall mortality has been a little over 22,000. But as we all know, the COVID-19 epidemic started from China, and yet their mortality rate has been extremely low. And we'll get to why they've been able to control the virus so effectively since its origin. The economic impact of COVID-19 is also enormous, measured in trillions of dollars just in the US alone. 16 trillion estimated by Larry Summers and his colleagues. And most of that is attributed to loss in GDP and death and disability and the consequences of lockdown in terms of mental health. And the cost keeps rising. So that's really the, maybe the bad news of COVID-19, and some of which is quite devastating. The good news is that the pandemic appears to be slowing down, certainly across most of the world. North America has been hit the hardest on a per capita basis, followed by South America and Europe. And all of these continents are seeing some decline. In the case of North America and South America, significant declines in the incidence and mortality from COVID-19. Interestingly, once again, Asia, which was the epicenter of the pandemic, has experienced very low rates of both incidence and mortality from COVID-19. So one question I think a lot of people are asking is, how did we get COVID-19? Clearly it was imported, but how did COVID-19 make it to Canada? So as noted, the epicenter was the Wuhan province in China, and it was exported across the world, first to other parts of Asia, then to Europe, particularly Italy and United Kingdom, and then subsequently to North America. And the first places that were noted to have COVID-19 in North America was the Pacific Northwest and Vancouver. Now, Vancouver has its source of COVID in two places. One is China, and the other, as you can see from this line, is Iran. So those were the two places where the COVID was imported into Canada. So if we go back to this map again, the paradox or the irony is that China and other parts of Asia have experienced very low mortality rates of COVID. So how were they able to contain the virus? And the answer is found in this set of slides. So there are two important concepts here. One is R. That denotes reproduction number. So number of new infections caused by a single COVID patient. And a reproduction number of 1 would mean that a single patient transmits the virus to another person. And a number above R, number above 1 indicates that you will have an epidemic in that community. So for COVID, the R is anywhere between 2 to 4. And that's why with coronavirus, there is propagation and exponentiation of cases leading to a pandemic. So that's the first important concept. The second important concept is about travel reduction. So in December of 2019 and into early January of 2020, there was an exponential growth in the cases of coronavirus in Wuhan. And on January 23rd, the Chinese government instituted a flight travel ban. And you can see the effect of the travel ban on the number of cases. There was a dramatic reduction. But that alone was insufficient to control the virus because after this initial reduction, there was a steady incline in the number. So on February 1, China instituted an overall country ban of travel. And that made a very modest dent in the number of cases, after which there was a continued rise. So that's assuming that the R was 1. So it's better than the 2 to 4, but not below 1 where it's needed to control the pandemic. So what the Chinese government did was instituted not only travel bans, but other measures beginning in middle of January to reduce the R number from 1 to 0.5. And you can see with a 90% reduction in travel plus a reduction of R to 0.5 that the epidemic was nearly controlled, nearly abolished, at least for this period of time. Some regions in China didn't quite reach 0.5, they reached 0.75, and even that was fairly good in controlling the virus, spread of the virus, though not completely so. So here's just an overview of what interventions were implemented in China. So this is R on the y-axis, going from anywhere between 2 to 4, which is the natural rate of COVID-19. And then on January 23rd, as mentioned, Wuhan, the province underwent a lockdown, and there was home quarantine. So this was a very effective way, quarantine, to reduce the R from about 4 to almost 1 over a 2-week period. Then this approach was implemented throughout the country, not just in Wuhan, but throughout the country with centralized quarantine and improved medical resources. And they were then able to reduce the R to 0.5 and lower throughout. And they've been able to do rapid testing, quarantine, and with complemented by travel bans and other measures, China has been able to keep the R below 0.5 since March 8th. And that's how they controlled the spread of the virus and reduced the mortality rate. What's happening in British Columbia in terms of R? So number of cases runs anywhere between 400 to about 600. And that remains throughout. And that has been fairly steady since around Christmas. Our R rate had been above 1 prior to the more strict lockdown measures that were implemented at the end of November. But we haven't really gotten the R down to where it's needed to control the spread of the virus. That's why our rates, the number of cases remain around 500 per day. And so this is just a summary of the Chinese experience. The importance of R, the reproduction rate. If you are able to reduce it to 0.5, you largely eliminate the pandemic. If the R remains at 1, regardless of what travel reduction you do, these effects are only transient and community spread remains relatively rampant. So as we talk about reopening of the economy, both here and the US, I think we have to be mindful of some of the scientific data surrounding that. So these data are modeled based on reopening of specific sectors of the economy. And the x-axis plots a number of additional infections one would expect per 100,000 individuals with full reopening of, say, restaurants or fitness centers. So the number one impact, adverse impact, would be associated with full opening of restaurants. And that's because there are so many restaurants relative to some of the other stores. And the fact that people stay in restaurants for a meal a lot longer than they stay in a drugstore. So as we contemplate full opening of the economy, one has to expect some increase in the case rate unless some other measures are taken to mitigate that. And they're listed in the order of their impact from the highest to the lowest. And on the right side of the ledger, I show you the impact of full opening versus partial reopening. If our case rate, say, is 500 per day, by opening up 100%, we would have an exponential increase in the case rate. But even with a partial lockdown, there will be a substantial reduction in the increment expected. So it's not an all or none phenomenon, and governments, local and provincial, have to be mindful of these data as they contemplate reopening the economy fully. So how can we return back to pre-COVID days? Can we return to normality or normalcy? And what is that definition? And the key here is herd immunity, and I'm sure you've heard of this. It's the herd immunity is achieved when approximately 70% or above of the population have developed antibodies or cell-mediated immunity against the coronavirus. And these data are model data that was published in The Economist a few days ago. So in the US, these are US specific data. In February, middle of February, about 40% of the population were thought to be immune to COVID-19. And that was on the basis of a relatively small rate of vaccination. And based on their projection, the best projection, herd immunity in the US can be achieved by the summer. Now, I think the vaccination rate may be a little bit higher than what was projected. So perhaps herd immunity can be achieved even before then. So the key to herd immunity, at least with COVID, is vaccination. It's unlikely that we will reach herd immunity through a natural process. So if that's, I'm going backwards, sorry. If that's the case, then vaccination is the key to reopening the economy safely. And the leader in this field has been Israel, with more than half of its citizens being vaccinated at least one dose. Canada is picking up the vaccination rate, but it has been very, very slow, and it's around 5%. And you can see that United States and UK both have rates that are much higher than that of Canada. So the reason I show you the Israel experience is that they now have very robust data about the effect of vaccination in their community in terms of COVID-19 infection rate. So this graph compares the vaccinated, which is in blue, versus the unvaccinated population in Israel, which is in red. And the curves diverge around day 14. It takes about 2 weeks for an individual to develop immunity against the vaccine. And so you can see that after 2 weeks, the blue line is flat, meaning that there are no additional cases of COVID-19, whereas the red line continues to rise in a linear fashion. And that's true of infection rates, hospitalization rates, and perhaps most importantly, death rates. The vaccinated population, almost no one died from COVID-19. So drilling down these data a little bit further in Israel, so they've instituted aggressive vaccination policies beginning in December 20th, 2020, and they targeted those over the age of 60. And after 2 weeks, you can see that there is tremendous divergence of the curve between the vaccinated and the unvaccinated in terms of patients ending up in the intensive care unit. So very, very sick patients. You would expect the 70-year-olds to end up on the ventilator, but because they were vaccinated, the curve is flat. And that experience has carried over to places like the United Kingdom. This is a kind of a busy slide, but the bottom line is after the second dose of the Pfizer vaccine, there is over 90% protection against coronavirus after 7 days post second dose. And even with one dose, there is partial protection up to about 60% on day 28. So I think that's given some confidence for us to give the second dose a little bit later than 1 month. The development of vaccine is truly a remarkable experience in history. We've never seen anything like it. So December 1, 2019 was when the first case of COVID-19 was documented. And it was January 10th, 2 weeks later, or about a month later, when the SARS-CoV-2 virus was sequenced. And 5 days later, National Institutes of Health designed the first RNA vaccine in collaboration with Moderna. And you can see the timelines such that by November, there were announcements from both Pfizer and Moderna of a very, very successful vaccine with efficacy well over 90%. And mass implementation of the vaccination programs began in late December. So in about 12 months' time, we went from not knowing anything about the virus to having a very, very successful vaccine. This is a table that summarizes all of the vaccines that are on the market or very close to the market. Here in Canada, we're getting largely Pfizer and Moderna vaccines. Soon we will get AstraZeneca and Johnson & Johnson. I think Quebec has already received AstraZeneca vaccine and they will deploy it. AstraZeneca vaccine is less effective than the mRNA vaccines for mild cases, but for severe cases, it's highly effective, as are the mRNA vaccines. So another thing that has arisen over the past 8 months is the notion of variants, or some people call it scariants. So viruses mutate, and this is a well-known fact. It doesn't matter if it's coronavirus, influenza, rhinovirus, doesn't matter. Viruses will mutate. Some will mutate to less virulence, some will mutate to increased virulence. And obviously the latter category is of great concern to public health officers. One of the first that was discovered or characterized were the variants from the UK, and specifically from the Kent region. It was called B117. And as denoted by the red, it's a mutation that's been associated with some antibody resistance. And certainly it's a mutation that is known to increase transmission in the community. And in many jurisdictions now, this variant has become the predominant variant for COVID-19. But there are a whole bunch of other variants that are coming out, several from South Africa, New York, California, and every day it seems we're getting new variants. Most of the variants are trivial and immaterial, but there needs to be continued surveillance for the variants that will escape the immune response, and thus the vaccines may not be effective for those variants. So far, I don't think we've discovered those kinds of variants yet, but it's possible. So going forward, the armamentarium for COVID-19 will be vaccination, rapid testing, and therapeutics. And let me just touch upon those things in the remaining part of the talk. So this is how the viral load changes in someone who's infected with COVID-19. Initially, for about 5 days, there is a slow amplification of the virus, and the patient is asymptomatic at this point. And then after about 5 days, the viral load really increases, and the patient becomes symptomatic and infectious. This is called an infectious phase, and that lasts for 7 to 10 days. And then there's a post-infectious phase. Here you can detect the virus by PCR, which is the hospital-based testing system, but the patients are not infectious at this point. So rapid antigen tests have been evolved to detect individuals who are in this infectious stage of the disease. So rapid antigen tests probably cannot detect individuals who are in the post-infectious part of the disease, or in the very, very early asymptomatic phase. It may have trouble detecting such individuals. The advantages of the rapid antigen test is that it can be used in a variety of different settings because it's relatively quick, relatively inexpensive, and I'll show you a kit that only costs $6. And it has a very fast turnaround time, less than 20 minutes. The standard tests are highly accurate, but it takes a day or two for the results to come back, and it's quite expensive to implement. One such test is called PANBIO ABBOTT. A company named ABBOTT produced this PANBIO kit, and this compares PCR to the PANBIO kit, and where there is black and white circles, that means there's concordance in the data between the PANBIO and PCR. Where there's discordance is when the individuals have very, very little amount of virus, and probably not an infectious individual, there will be discordance. So this is how the PANBIO kit works. There's a control line. You put the patient's nasal swab in here with some reagent, and after 15 minutes, if another line appears, the patient is infectious and should be quarantined. If there is no line, that means that they're negative and they're COVID-free. So that's how it works. Very, very simple. Can almost be self-administered with proper training. So we did this study comparing different types of rapid antigen kits, PANBIO, Artron, and one other. And just to show you that in the laboratory setting, these rapid antigen tests are very, very good for infectious individuals who have cycle thresholds of less than 25. These are infectious individuals. 30 or above are non-infectious. There's a little bit of discordance, but that's probably because the viral load is so small and that they're unlikely to be infectious. So with these data, we implemented a screening program at YVR to determine the feasibility of rapid point-of-care COVID screening of departing passengers, and to understand the acceptability from a passenger perspective of this kind of test. And these are the inclusion and exclusion criteria. We focused largely on domestic flight and individuals residing in BC. So if they had to quarantine, they could stay at a place in British Columbia. And if they tested negatively, then they were allowed to fly. If they tested positively, they would be immediately taken to quarantine, and there would be a confirmatory PCR testing. And they would have to stay in quarantine until they became negative, or 2 weeks afterwards, the test. We just completed the study. We were able to test 594 subjects. We did not find a single positive cases. And we know that these are all true negatives. We've done PCR testing on all 594, and they were all negative. So at least in the selected population, the prevalence of COVID-19 is extremely, extremely, extremely small. We can't say zero for sure, but it's very close to zero. Now, in contrast, we've done a similar study in long-term care facilities, and where we tested around 700 individuals. 700 were negative, but we found 2 completely asymptomatic healthcare workers who were positive and confirmed to be positive on PCR. So this is sort of the trajectory of the YVR test. We had a lot of up and downs because of various policy changes that happened with travel over the 2 months that we did the study. Another project that I'm involved in is the CORA project, where this is not a rapid antigen test, but it is a form of amplification. So it's quite similar to PCR, but the amplification is done without a big thermocycler and can be done in a very, very small tube. And then the readout is between 20 to 60 minutes, as opposed to 1 or 2 days for the PCR. And it's cheaper than PCR, but it's more expensive than the rapid antigen test. And this is what the prototype of the kit looks like. And we're still going through the regulatory process to get this onto the market eventually. And I don't know if, I don't think this works, but anyway, so I was going to show you how this thing works, but I don't think the video is working. No. So we'll just move along. So this is the virus at a molecular level, and it binds to this receptor called ACE2, and that's how it gets into the host. And what we did is just ask the question, can simple inhalers that contain steroids reduce ACE2? And what we found was that over a 3-month period, that these steroid medications indeed did reduce ACE2. And this may be one of the reasons why asthmatics and patients with COPD may be less likely to get COVID-19 than their counterparts. So in the last few minutes, I want to go over the medications. So this is a slide that I think in some ways I've shown previously. So there's an incubation period, and there's a mildly symptomatic phase. And this is where viral control is essential. And then if viral control is not done properly, then patients enter into this hyperinflammatory state. And in about 1% of patients, they move on to critical care state and mortality. So that's what the virus looks like. Viral control is very, very important in the early part of the disease. And then control of the inflammatory phase, which is the fire within the lungs, have to be addressed. So the first drug that came onto the market to control this was remdesivir. There are several other antivirals now coming onto the market. Convalescent plasma was used quite widely, especially in the US, for viral control, and it seemed to have modest effects. And then more recently, monoclonal antibodies have come in to control the virus. In the inflammatory state, steroids are the most effective, given through intravenous or tablets. And then more recently, tocilizumab, which is an anti-IL-6 monoclonal antibody, and several others are coming in to fill this space. So I was asked to speak briefly about the monoclonal antibody, one that was locally produced, bamlanivimab. I'm not sure, I probably butchered the pronunciation, but the original name was LY-CoV555. And in this study, they targeted individuals with mild disease, so very early on in the disease course. And they looked at the median number of days since onset of symptoms, as well as hospitalization. And I'll just show you the hospitalization data for the 2 studies that were published here. So placebo, the hospitalization rate in this cohort was about 6% at the 700 milligram dose. And it doesn't matter whether increased dosing was used. The rates of hospitalization were quite low, around 1 to 2%. So there was a tremendous reduction in the risk of hospitalization in this mild population. And that also translated into improved symptoms. And this is a graph showing that the LY-CoV555 was associated with rapid resolution of symptoms compared to placebo. So then the company moved on to target the sicker patients. So these were not the mild cases. Now they're in moderate to severe cases, and many of them, over 70%, were on supplemental oxygen. Here, the data were not as striking when they looked at time to a hospital discharge, and everybody had to be hospitalized to get into this study or sustain recovery. There was really no difference between the LY-CoV555 and the placebo for either of the endpoint. So FDA has come out. They have endorsed the monoclonal antibodies and authorized its emergency use for mild or moderate COVID-19 considered to be at high risk of progression to severe disease or hospitalization. but it has not been beneficial in hospitalized patients. And I believe that there are additional studies underway to address this further. So remdesivir is still considered to be effective for viral control, and dexamethasone to control the inflammation. And the dexamethasone data are really striking. There's those assigned to dexamethasone experience 17% lower mortality. And among those in the intensive care unit where mortality rate is very high, you can see without treatment, it approaches 50%. There's a 36% reduction. So more than 1/3 reduction in mortality with dexamethasone. It's a tremendous improvement there. So you can see that there's been tremendous improvements in both the therapeutics and prevention of COVID-19, and I think we're on the on the edge of having the pandemic lifted, perhaps in the summer for countries that have an accelerated vaccination program, and perhaps in the fall for Canada at the current rate of vaccination. So with that, I want to thank you once again for giving me an opportunity to present and update you on what we've learned over the past year in terms of COVID, and I will be happy to entertain any questions. Over to you, John.
Thanks very much, Don. That was great. A lot of technical material, but I think the message is pretty clear in terms of there's been a lot of scientific action that has gone on, and maybe that's not a bad place to start. We have a lot of questions already from our listeners that are online, but maybe start with a couple of just maybe personal observations from a scientific perspective. Both in terms of both treatment and in terms of vaccine, it would appear that what we're looking at is an extraordinary rate of adaptability within the medical community to be able to create this kind of treatment. Have you ever seen anything like this before? Anything close to this?
No, not even close. This is unprecedented. This is, the U.S. gave it the name Operation Warp Speed, and indeed, I think it's warp speed. The way in which all of these therapeutics and vaccines and other things have developed. I mean, there have obviously been some hiccups in terms of implementation, but in terms of development, it's been truly remarkable, and I think we should be very proud of not only the scientific community, but also the general public for participating in the clinical trials necessary to get these drugs onto the market.
Does this change your view of things as they will evolve in the future? I mean, there's a lot of talk today about, the next versions of, and I don't just mean the permutations of COVID-19, but basically the next viral impact that will occur, and seeing this very fast medical response. Do you see things being different in the future in terms of how we respond to viruses generally?
Well, for sure. I mean, I didn't get into this, but one of the reasons why the Asian countries were able to effectively suppress the virus, even without therapeutics and vaccine, was the fact that they had the experience with the original SARS and MERS, and they knew what to do. So when they saw that this was going to be an epidemic, they knew the response that they needed to take to control the virus. Unfortunately, the Western world was totally unprepared for that, and we suffered the consequence. So I think the next time, hopefully there won't be a next time, but if there is a next pandemic, we'll be in a much better position to respond, both from a scientific perspective, but also from a public health perspective and regulatory perspective, to ensure that this doesn't get out of hand.
So, I mean, Don, the way you described your timeline at the beginning, the Chinese tactical response to managing the outcome of the virus, not just in Wuhan, but in the country overall, was relatively quick and very specific as it related to both a travel ban and effectively a lockdown or a quarantine. And the impact of that was being felt and measured. Now, I don't know, was there some reason Western countries, having seen how effective that was, because they had this sort of 2-month lag into March, didn't consider that that would be a defining way to manage the issue until treatments and vaccines came into play? Because it doesn't look like virtually any of them did that.
Well, I don't think any of the governments were prepared. I don't know if and I don't think the public was prepared. I mean, would we have accepted a full lockdown on March 1 or in February when we noted the first cases? So, so I think there are a lot of things that we were unprepared for, both from the government perspective and from a societal perspective. But I think, the next time we have this infectious disease or something similar, I think we'll be much more prepared and we'll be, implementing those policies, I think, at a much earlier time point and much more aggressively than we did this time around. We were totally unprepared. I think governments that responded a little bit better had better outcomes, but there were a lot of, as you know, a lot of political discourse and a lot of waffling. Made it very difficult.
So you don't mind if I ask a couple of politically incorrect questions? You don't have to answer them, but I think okay, I feel the need.
I'll try not to
sort of ask them. Okay, so I'm just interested in your scientific point of view of whatever the benefits may or may not be in having returning passengers test again. They've tested obviously before they've left their locations, and then be required to stay in a hotel as opposed to quarantining at home until the results of those tests are received. I mean, from your perspective, are we getting some scientific medical benefit by this additional step in the case of this staying in the hotels?
I think if there is a benefit, it's very incremental. It's very small, and I'm not sure it's measurable in any meaningful way. What the more strict travel bans have done is really taking down the number of passengers, and maybe that's the impact that
so the volumes are down, obviously.
Yeah. So maybe that's the true impact.
And why wouldn't, given what appears to be the efficacy of the rapid testing that you were talking about earlier, and the work that you did at YVR, why would that not be the default test that was actually used? Because presumably somebody could land, get tested, wait an hour or two, and the results would be known, and then you would just go home.
Well, some countries have implemented that. So, for instance, the Netherlands, if you want to go and travel into Netherlands, you have to get the rapid test at the time of boarding, or
right. Okay.
So, I think that's a very progressive policy. I think that's a very good policy. What I would like to see is rapid testing at the time of boarding and rapid testing when you land.
Yeah, that seems logical.
And then rapid testing thereafter for a couple of days until you know that you're out of that window of incubation period. So I think these things are doable, but it takes, I think political will to do it, and I'm not sure we have that political will.
Well, thanks, Don, for a really honest answer. That was great. Okay, just before we get into the other questions from our listeners, when people talk about returning to normal, I guess they're talking about returning to an environment that we were experiencing, let's say, Christmas 2019. What is your thinking about when we will see that kind of environment, or will we see that kind of environment? Are there going to be sort of permanent aspects to the way we behave or the way we interact, or whether we distance or use masks? What's your thinking about how this will all play out?
Well, it's hard to predict for sure, but this is what I think will happen. I think we will reach herd immunity through vaccination, perhaps as early as the fall or summer in the case of the US. But we will still have coronavirus in the community at a low rate, and it may be the variants that will persist. And what is unknown is whether the vaccination will protect us in perpetuity against those variants, or will the variants ultimately win out and cause another epidemic or perhaps even a pandemic. So I think even when we return to so-called normalcy, we still have to be, I think, mindful and very careful about the potential for this and other coronaviruses to gain footing into the community. So I don't think we can go back to the same practices as we did in 2019. I think we need to be a little more careful in terms of our hand washing, about our use of masks, social distancing, and so forth.
So there's going to be some permanent adaptation to this
I believe
reality.
so.
Yeah.
I believe so. It has to.
All right, so some questions from the group. So this is from Gary Jackson, and he asks, how accurate are the data from developing countries?
Good question. I'm not so sure they're very accurate in terms of, because they lack the resources to have mass testing. So I think a lot of the data we're getting are estimates. Perhaps in some countries, they're very good estimates. In some other countries, they're very poor estimates. In terms of mortality, we have no idea. Mortality data are all over the place and probably not reliable. We know that for sure in places like Iran. I'm sure that.
So not all causes of death or sickness that occur are being allocated maybe appropriately to the impact of COVID. Is that really what the problem is?
Yeah.
Yeah.
Because they lack the resources to test individuals.
Yeah, fair enough. Okay. Here's a question from Robert Reese. He asks, how concerned should we be that the vaccines are experimental and not tested in the long term?
Experimental in what sense?
I don't know the context of the question.
Anyway, they've gone through large phase 3 trials. So this is the gold standard for how vaccines or any therapeutics get onto the market. And FDA and Health Canada have rigorously evaluated the data. So at least for the period in which these experiments were done, the vaccines are highly efficacious. I think what the question probably is asking is what's going to happen in a year's time when we don't know the data. But that's always been the case for all vaccines. But we don't measure out to 10 years.
And okay, so you're the scientist here, Don. I mean, my understanding is that generally with vaccine therapy, the research requires many different kinds of tests because so many approaches are going to fail that you need many of them in order to succeed. But in this particular case, just my imagination, but there are 4 or 5 already successful vaccines from a variety of drug companies. It's almost like they all seem to work. I mean, was there any science going behind, like, is there something special in the pre-screening that's allowing
I think it's just, that's an excellent question. I think it's the fact that science has evolved very, very quickly. And so the vaccination programs are really targeted and they weed out all of the poor candidates very early on in the development. And what you see are the best of the best. I can show you, 2 or 3 pages of failed, therapeutic and vaccine strategies. Yeah. So what you see is, from millions of potential targets to the 3 or 4 that have been successful.
We've sort of dealt with this question, but let's ask it again anyway. This is from Rob Lucy. If there's a new and just as deadly virus in a year or 2, will we have to go through all of this again, or do we know something valid shortcuts as a result of this particular experience?
Well, I think it really depends on the virus. So perhaps some of the therapeutics and maybe even the vaccine that we've developed for coronavirus can be repurposed for the new variant or new virus that evolves. The second is that I'm 100% positive that we will lock down much quicker both our borders and our city, and that will contain the virus. The measure of quarantine and lockdown is a highly, highly effective strategy of reducing the R, which is the reproduction number. That's the key of controlling the virus.
So here's a question, because obviously no matter how rapid the vaccine research was going to be, the simple length of time, even this was miraculous, but you still have to do testing. And so, here we are inside a year and we've got some results. But in the meantime, let's imagine at the beginning of this exercise, going back to last spring, a year ago, that we had in place both a combination of rapid testing and treatments like dexamethasone, or I think it's Lenivibab, if that's the correct pronunciation.
Okay.
But these are treatments for early stage, right? And
Mhm.
so would that would we have seen a material impact both in caseload and death rates had they been effectively in place at the beginning?
Oh, for sure. For sure. We know that. And you know that based on anecdote. You saw, Mr. Trump, who developed
Yeah,
COVID-19 and received the Regeneron form of the monoclonal antibody,
yeah,
recovered, within 24, 48 hours. So,
yeah.
so absolutely. If we knew then what we know today, we would have far fewer deaths.
So I mean, I don't know how one actually prepares for that, but that would be an area that one would focus on, would it not, to try to manage the problem until you actually had effectively a vaccine or essentially a cure for the very underlying issue.
So I think what's going to happen once this pandemic, disappears, is that that the research platforms that led to the development of these therapeutics and vaccination strategies, to a certain extent, will remain viable.
Hmm.
And so, if the next pandemic, hopefully, it doesn't happen in our lifetime, but if it does,
Yeah.
then there will be rapid deployment of the therapeutic testing and vaccination strategies.
So would we hope to see maybe a higher degree of coordination and cooperation amongst countries next time out, a faster response with a collective sharing, of intellectual property and processes at work?
I would hope so. I think this time around, international cooperation was pretty good, and that's, I think, evidenced by the fact that within 9 months we got an effective vaccine and multiple therapeutics.
Yeah.
So, can it be better? Yes, absolutely, and I think governments will respond, more promptly next time this happens.
So here's a question from Deepak Suri. He says, can masks stop from inhaling virus if a person comes in contact with a person carrying the virus?
That's very controversial. My personal feeling is that the viruses are a little bit too small, and they'll penetrate most surgical masks, unless
Hmm.
you're talking about N95, Darth Vader type of masks.
Right.
They cannot weed out the virus. So I think the mask should be worn, but probably for a different purpose.
Right. So do they help? Then the flip side of that question would be, how effective would the mask be in
They're very
preventing somebody
effective.
spreading?
They're very effective because the viruses have to be carried in water droplets to
Yes.
survive.
Okay. Yeah.
So they're highly effective in preventing transmission.
Yeah.
They're not terribly effective in you not getting the infection if somebody coughs on you directly.
Right. So they solve half the problem.
Yeah.
Yeah. Okay. From John Robinson, he wants to know where he can buy a COVID test today, or if he even can, I guess.
You can contact the province has a full stack of rapid tests in their warehouse. You can contact the provincial office, and they'll tell you where to procure these. So what happened in terms of these rapid tests is Abbott, one company, sold it to the federal government. So the federal government procured all of it, and then they distributed to each of the provinces. And almost every one of those provinces has an excess stack of these rapid antigen tests.
Just to be clear, Don, is there going to be a point here where there's going to be like a home test for COVID that you can
In the
just do for
US
yourself?
and parts of Europe, home test kits are available
Oh, okay.
for purchase. I think they're about $50, maybe a little bit more expensive than that. Yeah. So there's really no reason. So these rapid tests have now evolved to the point where you don't have to do a nasal pharyngeal swab. You can just do a little nasal swab, just tickle your nose,
Yeah.
and then put it into a solution, and the solution changes color. If it turns red, you have the virus. If it remains clear, you don't have the virus. So
I mean, would that not, I mean, practically speaking, in terms of people's behavior, attitudes, and things like that, wouldn't the access to something like that at least give some people comfort about where they were personally?
I would think so. I think so. And imagine, sporting events and theaters and things like that.
Oh, I can. Yes,
Yeah.
100%.
Yeah.
This is from Lawrence Chu. He's asking, when considering the impact of the reopening chart that you had, how did the model factor in school reopening? Or, I mean, arguably schools are reopened in some limited way, depending on the nature of the school.
Yeah, in fine print, there's actually school reopening.
Yeah.
That's a relatively small impact in the caseload that increases. There will be some increase in the number of COVID cases once you reopen school, no doubt about that. But the overall impact on society is relatively small. The bigger one is the restaurants.
Right. So one of the things, and it just occurred to me, and this is actually sort of quasi-connected to the school reopening, but seemed to me from the small amount I've read about the Spanish flu that there was a huge impact on relatively young people and children that was significant in terms of morbidity and mortality. But that's not the case here with COVID. In fact, there's a steep curve, and obviously being significantly older is a massively higher risk. So is there anything we would learn from that? Or what is there a future expectation that the age factor or the other morbidity factors are the ones that are going to drive the outcomes?
No, it's viral specific. So the reason the COVID-19 is more devastating in older folks is because the receptor is highly expressed as you get older and develop more comorbidities. So the reason children are not super spreaders and they don't get terrible disease is that the receptor is scarce.
Okay, so basically it can't
so
be
it's
attached to them
really,
that easily?
yeah, it's really viral specific. Influenza uses a different receptor to get in to the respiratory tract.
So here's a question from Gary Jackson. He's asking, any further information on, I'm pronouncing this correctly, I hope, fluvoxamine to prevent severe COVID-19?
I think there are a lot of therapeutics that have been purported to do that, but that's a drug that I haven't seen come through a phase 3 trial. So right now, I don't think it's approved for COVID-19, or will it, without phase 3 data, it will not be endorsed by the medical community.
Okay, and when is your own PCR test going to be ready for the market, or is it already?
No, it hasn't. The regulatory process is relatively long.
Okay.
This question, we hope within the next 6 months, but we're keeping our fingers crossed that all milestones are met.
It does seem painfully slow.
Oh, it's just, you won't believe it, John.
Okay. Now this is just a statement. Okay, here we go. Actually, it's let me just put these two together. This is from Christina Marzilli from, I think Christina's from Toronto. Many firms are closing or losing money due to COVID. How does this affect the stock markets? And where do we invest in the stock markets, low markets and grid markets? And I should ask you that question, even though in theory, that's the question I'm supposed to be able to answer, right? But do you actually have an opinion about that? I'm just curious.
I have no opinion. I'm the last guy you should ask about money and stock market.
Well, the interesting thing, of course, there's been tons of articles press. We are actually writing a newsletter on this, Don, and the reality is that probably the biggest impact on the stock markets over especially the last 9 months, or 9 to 10 months, has been the incredible pumping of cash into society all over the world. And the savings rates and the glut of savings is enormous. When you compare that to the impact that governments are manipulating interest rates and making them basically zero in terms of savings accounts, it means then that money will find its way into 2 or 3 other asset categories. The stock market is one of them, and that does explain some of the elevation in the markets in the last year or two, maybe quite a bit of it. And the second is the real estate market, and that is clearly occurring here in Canada. The market took a pretty big hit during the course of the summer, and the recovery since then has been nothing short of extraordinary. So as long as we have this combination of incredible government support blended with low interest rates, we probably will see a little bit of an elevated market, but at some point in time, it'll come time to pay the piper. The government won't print the money and the rates will go up.
Yeah. Well, I can't figure out why inflation hasn't gone up. But
well, I think that's an interesting thing, and we're digressing away, obviously, from COVID. But the general theory behind the lack of inflation over the last year is what's called money velocity. In other words, it's a little bit like pushing on a string. So I can put all this money as a government in society, but if all the people do with the money is take it and put it in a shoebox under their mattress, it will have no impact on inflation. And that's exactly effectively what they've done. Now, at some point, they're going to take the box from under the mattress and they're going to go buy some stuff. And then you'll start to see some inflation. So, but right now, we're not getting it.
Very good.
Sorry, didn't mean to digress from the topic at hand.
Yeah, it was.
Okay, a question from Catherine Miller. Is this vaccine going to be received yearly like the flu shot?
Well, most likely.
Most likely, okay, all right. And just to let everybody online know, it's now 11 o'clock and we are supposed to finish. So, but we're going to continue online for another 5 minutes. We got a few more questions and then we're going to wrap up. This is from Sue Munn. What do you think about delaying the second dose to 4 months, which is, I guess, a decision that's already been made?
Yeah, well, I think that's a public health decision. The governments want to vaccinate more people, at least once, and I think that's a good strategy given the scarcity of vaccines. But it's estimated that by summer there will be a glut of vaccines. So this 4 month delay will not last forever. In fact, I think by summer this problem will be resolved.
And this is a question from Paula Coronado-Haas, who asked this question. When do we expect to see vaccinations for children in BC? Will we reach community immunity without children being immunized?
I think we can reach herd immunity without children. Children are not terribly affected by COVID-19. They are doing phase 3 studies in children. So I think we have to get the safety data out before we vaccinate kids. Kids are too precious to just treat them like young adults.
So here's our last question that we have with respect to the time we've got. From Heather Friesen, the question is, would you predict that we will see a natural reduction of COVID cases due to winter months being behind us and historical pattern of flu, cold, and respiratory illnesses diminishing as spring and summer approach?
So the case counts will naturally go down, but we've learned over the past year that the coronavirus on its own will not disappear. It will come back fiercely, maybe more fiercely in the fall. So we have to get our vaccine strategy in place, during this window between the springtime and early fall. We have to get it. There is no option, and so I think the government understands that, and I think they have a plan in place to enable that, and that also includes the lengthening out for four months between doses for the time being.
Well, Don, listen, this has been hugely informative and very helpful, and I would say, generally speaking, certainly more positive than negative based on where things looked the first time we had our discussion about 8 or 9 months ago. So I want to thank you for being able to join us again and giving us this update. I think it gives a lot of comfort to a lot of the people that were listening today, and other people will be able to listen to the webinar. It will be posted on our website, so you'll be able to download this and listen at your leisure. And again, many thanks. We really appreciate this, Don.
Well, thank you. I enjoyed it, and great questions. Love it.
Okay. All right. Thanks, everybody. And thank you for joining us. And we'll look forward to one day having an additional session with Don, when hopefully we can say we are definitely past the herd immunity stage. Thanks again, everybody. Bye-bye.
Bye now.